Thank you very much for having me speak. What I hope to do over the next 45 minutes or so is consolidate some of the knowledge that you've seen in some of the preceding talks on the hematological malignancies, and I'll sort of bind them by themes. There's going to be no surprises. I'll more or less tell you what section we're in, but I'll give you how I think about these diagnoses as a hematological pathologist. I did also include a set of sort of self-assessment questions that are similar type cases that without the sort of other commentary that you can sort of afterward judge my effectiveness as a teacher and also your consolidation of the knowledge afterward. So a lot of hematopathology in the heme malignancies involves understanding lineage differentiation, and I put this slide up here just to remind you that there are a large number of lineage-specific markers, but you can break them down into thinking about them in certain ways. So, for example, CD45 is an antigen that's present on all hematopoietic cells. Solid tumors don't express CD45. There are certain immaturity markers, including HLA-DR, CD34, and TDT for the lymphoid lineage, and CD117 for the myeloid lineage. You can remember the B lymphoid markers because they're the late teens, early 20s, 19, 20, 21. And the T cell markers are all the markers CD8 and below. All right? And K cell markers end with 6s. They're CD16 and CD56. And the myeloid markers are the early teenage years, CD13, 14, and 15 with the addition of CD33. And in addition, there's myeloperoxidase and lysozyme. Myeloperoxidase being the most important lineage-specific marker for the myeloid lineage. This talk has a lot of flow cytometry scattergrams. In some ways, they're actually page filler because you don't actually have to interpret flow cytometry scattergrams, but I do want to remind you that if you can remember some basic tenets of flow cytometry, you can nearly instantly recognize a tumor, particularly within the lymphoid lineage, as something as being an abnormal phenotype. For example, if we look at B cells, CD19 is present on all B cells, and CD19 tends to increase in intensity as does CD45 as B cells mature. And then if you do a two-color plot for CD20 and CD10 in those CD19 positive B cells, the most immature B cells here, they're colored yellow, which would be the CD34. Most immature cells are down here at the tip of the snake, or the S, as some people say, and the B cells mature up. They gain CD20 and they lose CD10, such you have the mature surface immunoglobulin positive markers here. And if you can just fix this sort of what we call hematogone plot of B cell maturation in your mind, B cell leukemia usually deviates in being a population often that's brighter for CD10. Than the normal hematogones. Something is similarly true for CD3, CD4, and CD8 in the T cell lineages. So let's look at a few cases of acute lymphoblastic leukemia. The first one is a 6-year-old girl with trisomy 21 and cardiac anomaly, status post-repair, now with lethargy and pallor. She presents with a white count of 5.7, an anemia that's presumably normocytic, a low platelet count, and 87% blasts. These blasts are small. If one had a normal lymphocyte, perhaps that being the closest cell to a normal lymphocyte, the blasts are only a little bit bigger than the normal lymphoid cells. They have this sort of immature appearing chromatin that has some degree of coarseness and not particularly prominent nucleoli, and they have relatively scant cytoplasm, and they're somewhat variable in size. So I think you should recognize this as being the morphology of lymphoblastic leukemia. Here, if you go to the flow plots, you can see that these are CD19 positive cells that are very dim for CD45. They're positive for HLA-DR, so those are both markers of immaturity. They're CD19 positive and CD20 positive only in a subset. CD20 occurs later in B cell differentiation. They're positive for CD10 or CALA, the common ALL antigen. They're surface immunoglobulin negative, and they're TDT positive. So we're dealing with an immature B cell tumor because they're TDT positive and surface immunoglobulin negative. Here's a reminder to show you that TDT is an intracellular antigen, and we have to do special testing that permeabilizes the cells to do that. In addition, by flow cytometry, we can also look at the DNA index, which is sort of a shortcut into looking at what the total chromosomal complement of the cells are. Here, the DNA index is about 1.2 times that of normal, so a DNA index of 1.198 or 1.2, and this indicates a hyperdiploid clone present in this sample. That was confirmed by the cytogenetics, showing that there were the constitutional chromosome 21. In addition, this patient had a high hyperdiploid karyotype that included the so-called triple trisomies of +4, +10, and 17. So let's talk a little bit about B-cell cytogenetics. High hyperdiploid BALL, defined as having 51 to 66 chromosomes, is about 25% of cases of BALL. It corresponds to a DNA index of greater than 1.16 in most cases, and the most common gains are those triple trisomies 14 and 21 and X. High hyperdiploid E is the most common cytogenetically evident karyotypic abnormality in BALL. TEL-AML1 is, by contrast, the most common translocation in BALL, and it has about the same incidence. However, the translocation is cryptic, and you need to do FISH or RT-PCR in order to identify it. It's often associated with the deletion of 12p, which is the other chromosome that contains the TEL locus. So that was historically a marker of TEL-AML1 positive ALL. Very few ALLs have a distinctive morphology. One that does have a distinctive morphology is the T514, the IL-3 IGH translocation, which presents with profound eosinophilia. Another ALL that's commonly seen in about 5% of the cases involves a chromosomal 119 translocation or the E2A-PBX translocation. Down syndrome ALL, unlike in this case, usually has a normal karyotype. The patients with Down syndrome ALL typically, in about 50% of cases, have rearrangement of CRLF2. So this case was a little bit of an unusual case insofar it was sort of typical high hyperdiploid ALL presenting in a patient who happened to have Down syndrome. More about BAL cytogenetics. Let's move on to the bad actors, and those are the ones that put the patients into higher risk categories. MLL rearrangement, it's the most common rearrangement in infants. It's an 11q23 abnormality. It's sometimes cryptic, and it may require FISH to confirm it. Philadelphia positive BCR-ABL translocation, as you know, is increasingly prevalent in older patients. It can be detected by karyotype, FISH, or PCR. An RT-PCR that indicates a protein product of 190 kilodaltons is typical of de novo ALL, whereas a protein product of 210 kilodaltons is typical of CML and blast crisis, be it lymphoid or myeloid blast crisis. Hypodiploid ALL is another bad actor. It's defined as having fewer than 45 chromosomes. It's a very poor prognosis, and it can be associated with germline or acquired mutations in P53. There's the newly recognized entities of Philadelphia like ALLs where other tyrosine kinases are fused to promoters, including the EPO receptor, CRLF2, and these may or may not have mutations in the JAK proteins or in Ikaros. Ikaros itself conveys a poor prognosis, as does the interstitial amplification of the AML1 locus on chromosome 21. And then, of course, there's MYC translocations, which isn't necessarily a bad actor in ALL. It's just to remind me that it's actually a different disease and that it's really a mature B-cell lymphoma with a leukemic phase. Speaking of Burkitt leukemia or L3 leukemia, here's the typical morphology. These intermediate-sized basophilic blasts with this sort of cornflower blue cytoplasm and vacuoles that represent fat located within the cells. The nucleus is typically relatively round. There are multiple nucleoli that are peripherally placed, and the chromatin is not often particularly immature looking. It's more mature appearing, coarser, that is to say. Like BALL, these are B lineage markers that co-express CD19, but they're typically very bright for CD20. They're also positive for CD10, the common ALL antigen. CD10, in addition to being expressed in early B cells, is also expressed in follicular B cells. And unlike ALL, it's positive for surface IgM and the clonal immunoglobulin light chain, and negative for TDT, as is typical of all mature B cell tumors. So again, these are intermediate-sized lymphoid cells with mature chromatin and deeply basophilic cytoplasm that's often vacuolated. The distinction between leukemia and lymphoma is actually semantic. It really is for protocol purposes. I'll remind you once again that this is a mature B-cell tumor with a phenotype very similar to ALL, but that it's typically negative for the immaturity marker CD34 and TDT and expresses surface light chain. For your purposes, it's defined by the presence of a MYC rearrangement where MYC is brought in proximity to one of the three immunoglobulin loci enhancers. This is either the heavy chain, the light chain, or the light chains on chromosomes 14, 22, or 2. It's important to note that unlike in BALL, where most of the translocations result in fusion proteins, this is simply places the enhancer elements of the immunoglobulin loci adjacent to the MYC promoter, and so the MYC gene is overexpressed. So now we have a 12-year-old boy with a white count of 86,000 and an anterior mediastinal mass. This immediately should suggest T-cell ALL with both the age of the patient, the male, the high white count, and the anterior mediastinal mass. The morphology is typically not that different from BALL, but it does express a different complement of immunophenotypic markers by flow cytometry. The canonical T-cell markers that are present in most TALLs are CD2, CD5, and CD7. The cells typically are not so mature that they express surface CD3, but they do express cytoplasmic CD3. They may express CD10, and they typically express TDT and dim CD45. But unlike most other acute leukemias, save one other, acute promyelocytic leukemia, TALL is typically negative for HLA-DR. So again, the distinction between leukemia and lymphoma is a semantic one, similar to Burkitt lymphoma or leukemia. Unlike in B-cell ALL, here the T-cell receptor loci are the most commonly translocated loci, and in these cases they often do not result in fusion genes. The alpha and beta as well as gamma T-cell loci are commonly translocated with one of several HOX genes or other hematopoietic transcription factors that are important for hematopoietic and particular T-cell development. Deletions of chromosome 9p are particularly common in T-cell ALL. Here's another peripheral blood with showing blasts that are somewhat larger with more ample cytoplasm and more prominent nucleoli. I would have a difficulty saying morphologically if this was ALL or if this could be AML. By flow cytometry, this case, however, expresses HLA-DR, CD117, which is a myeloid marker, immaturity marker, CD34, and TDT. So we have sort of mixed messages here. This is a lymphoid TDT expressing tumor with a CD117, which is a myeloid marker. But it does also express other T-cell markers, including CD7, but doesn't express other T-cell markers such as CD5 or CD8. It also co-expresses a myeloid marker. In the days of yore, we might call this a mixed lineage leukemia or a mixed phenotype acute leukemia, but now we actually recognize this to be a phenotype that's associated with early T precursors, where here the immunophenotype is a CD1A, CD10 negative, CD8 negative, CD5 weak or negative T-cell tumor that often co-expresses one or several immaturity markers such as CD117, HLA-DR, and myeloid markers like CD13, 33, etc. Moving on to acute myeloid leukemia, this next case is a 16-year-old girl with pancytopenia and cells that one wondered whether they were peripheral, one wondered whether they were blasts. Here you have rather large cells with immature appearing chromatin, prominent nucleoli. The nuclei have this bilobed appearance, particularly if you look at the one that's in the center. There's abundant cytoplasm. There's abundant cytoplasm that does not appear to have granules, nor are there many hour rods. If you look in the background, there are some cells that have sort of more heavy granules, and this is a difficult morphological call. Some of these cells look like monoblasts, but if I were to show you a patient with another patient with the same chromosomal translocation, you can recognize what this is. Here's the same chromosomal translocation presenting in a different manner. Here, these are easily recognized as hypergranular promyelocytes. The typical immunophenotype of acute promyelocytic leukemia, which, as I noted before, is an HLA-DR negative, CD34 negatives, because these are more mature cells. They co-express myeloid markers and are characteristically very positive for myeloperoxidase. APML is defined by the presence of the 1517 translocation, which translocates the retinoic acid receptor to a gene called PML, or promyelocytic leukemia, on chromosome 15. There are some variant translocations that are resistant to atratherapy, and for that reason it's important to recognize variant translocations in addition to the diagnosis itself. The classic hypergranular variant, or FAB-M3 acute promyelocytic leukemia, has hypergranular dysplastic promyelocytes, many with multiple hour rods that are intensely myeloperoxidase positive. As I said, they're HLA-DR negative, CD34 negative, and express other myeloid markers. The microgranular variant, which is the one that I actually showed you in the first slide, has these classic bilobed blasts with submicroscopic granules that are only occasional hypergranular promyelocytes. These cells, however, are still intensely myeloperoxidase positive. And importantly, it often has a variant immunophenotype in which it's HLA-DR positive, CD34 positive, and CD2 positive. So the take-home point here is if you see that bilobed morphology and you're even thinking that it could be acute promyelocytic leukemia, send the appropriate test, which is an RT-PCR test for the most rapid turnaround time. Here's a 16-year-old boy with a history of AML status post stem cell transplant, now with pancytopenia. So here you can actually appreciate that he actually has some normal hematopoiesis, including red cell precursors. It turns out to be very difficult to point with this because the slide advances whenever I do that. So there are erythroid precursors, some blasts that have more immature chromatin, such as this, some of which have folded nuclei that make you think about monoblasts, but particularly conspicuous are these cells with eosinophilic granules, and some of these cells with eosinophilic granules have these coarse, densely basophilic granules. The cells flow as myeloblasts, being CD13 and 33 positive for CD117, and it's not surprising that this case has an inversion 16, which translocates the CBF beta locus to the myosin heavy chain 11 locus. This is an inversion of chromosome 16. One can also have a T16-16 translocation. Here, this morphology defines the type of a good prognosis AML and FAB-M4-EO, or AML with recurrent chromosomal translocation and abnormal eosinophils. Here's another girl with AML with leukocytosis, anemia, and thrombocytopenia. Here's actually the Cellavision image that I was sent at home one weekend, which actually shows that the predominant cell in the peripheral blood in this patient are these abnormal appearing granulocytes and granulocyte precursors. In fact, there's only a very rare blast in the peripheral blood. Here's her bone marrow that came out several days later, and superficially this actually looks at like pretty normal myeloid maturation. You have immature myeloid cells, somewhat more mature myeloid cells, as well as some neutrophils, but there are occasional blasts in the background, and there's some dysplastic changes within the granulocytes. This patient also, by flow cytometry, had only a tiny number of immature CD45 dim blasts that co-expressed myeloid markers, as well as the lymphoid marker CD19. So this is a myeloid tumor expressing CD19 and also expresses dim TDT. So here's the flow phenotype, here's the morphological description. In this case, came back with a relatively typical chromosomal translocation of a T821 or an AML1 EDO translocation. And this hybrid phenotype of a myeloid tumor with myeloid maturation and a co-expression of TDT and CD19 is entirely characteristic of AML. And this is the most common simple translocation you'll see in AML patients in the pediatric setting. These two leukemias that I just described are two of the better prognosis AMLs and the so-called core binding factor acute leukemias. The inversion 16, as I told you, is typically an inversion but can be a translocation between the reciprocal chromosome 16. But it is often actually a cryptic on karyotype and requires RT-PCR or FISH to confirm. The T821 characteristically has this FABM2 or myeloid leukemia with maturation phenotype, and the cells often have salmon pink granules and long, slender hour rods, if you're lucky to catch an hour rod. This is typically cytogenetically apparent, but may be cryptic in a three-way translocation. These two leukemias, it's important to note, are not defined by their phenotype nor by the presence of greater than 30% blast. These are special cases where simply the presence of having these particular chromosomal translocations defines them as being AML. Let's move on to the subject of infants with acute leukemia. There's two questions that I ask as a hematopathologist whenever I'm asked to evaluate a specimen from an infant with a high white count. The first question out of my mouth is, how old is the patient? I want to know if the patient's less than a week old and whether or not the patient has Down syndrome. Those are really the two things that I need to know from the outset. So here's an infant female with a white count of 100,000 cells per microliter. It's morphologically typical lymphoblasts. These lymphoblasts tend to be rather small, and some of the cells have this sort of baby's bottom kind of cleave to them, which is very typical for this entity. By flow cytometry, these are B cells that are positive for the immaturity marker CD34, but unlike most ALL, BALL, these cells are negative for CD10. These cells also express a little bit of a myeloid marker CD15. And thus it's not surprising that this patient has a typical MLL rearranged ALL. MLL rearranged ALL often presents most typically presents in infants less than 6 months of age, and unlike most other types of ALL is CD10 negative and co-expresses a single myeloid marker, most typically CD15. So if you see that phenotype in an infant with a high white count, be thinking AML and thinking MLL rearranged ALL, and make sure you get the FISH. Here's another infant female with a white count of 100,000. And multiple non-tender violaceous skin nodules. These cells are larger, the chromatin's more immature, the nucleoli are more prominent, there's ample cytoplasm but no air rods. Sometimes you see cells that remind you more of monocytes or immature monocytes, such as these two cells here. These cells are all blasts, and they co-express the monocytic marker CD64. In this case, the karyotype comes back with something that's evidence of clonality, but there's no evidence of an MLL translocation until one gets to FISH, which demonstrates that there's an MLL translocation in this patient as well. So acute monoblastic leukemia is often very large blasts that are NSE positive, often involving the skin, CNS, and other extramedullary sites at diagnosis. MLL translocations, particularly in the infant setting, are common. There are many translocation partners, chromosomes 9 and 6 being the most common partners. But the chromosome 4, which is most prevalent in infant ALL, is actually relatively low down on the list. As I've said several times, this often requires FISH to identify the translocations. It should also be noted that MLL translocations are also seen in biphenotypic leukemias and in therapy-related leukemias in older age populations. Here's a 30-week preterm female infant with high drops and uncommon AV canal, presenting in the first week of life with a white count of 76,000, including 24% nucleated red cells, 68% blasts, a low hematocrit, a preserved platelet count, a bleeding diathesis, as well as some evidence of tumor lysis. Here's the peripheral blood. You can see these large basophilic appearing blasts, as well as the nucleated red cells. Some of these blasts even have some small blebs on them. Many of the blasts actually remind you of erythroblasts as well. By flow cytometry, this has a very crazy phenotype where it's an HLA-DR negative tumor. HLA-DR negativity is typical of megakaryocytic leukemias as well as TALL, as well as acute promyelocytic leukemia. It co-expresses two megakaryocytic markers, CD61 and CD41, as well as an erythroid marker, CD71, a T-cell marker, CD4, which is also expressed on normal maturing megakaryocytes, as well as CD7. And this phenotype is entirely typical of the phenotype that one sees in the blasts of patients with transient abnormal myelopoiesis of Down syndrome or transient myeloproliferative disorder. This is a megakaryblastic or hybrid erythroid megakaryblastic proliferation that occurs within prior to or within days of birth. I call it the 4 Bs. These are big blue blebby blasts. They have this very characteristic phenotype that almost never varies from patient to patient. The transient abnormal myelopoiesis are associated with either with constitutional or somatic mosaic trisomy 21 and somatic acquisition of a GATA1 mutation in exon 2 that results in a truncated form of GATA1 being expressed. As you know, 20 to 30% of patients with transient abnormal myelopoiesis will evolve to acute megakaryblastic leukemia. This typically occurs at less than 30 months of age and is usually associated with acquisition of secondary chromosomal abnormalities as well as additional secondary somatic mutations. Here's another big blue case of big blue blebby blast in an infant. This one here is actually the chromatin is relatively difficult to describe as whether it's myeloid or lymphoid. To me, it has a certain sort of coarse chromatin quality, but the cells remind me of those transient abnormal myelopoiesis blasts. You again can appreciate the blebs, and often sometimes can even see these blebs sort of circulating in a manner similar to platelets. Here we have another CD45 dim CD117 variable tumor that's co-expressing megakaryocytic markers. In this case, they comprise about 30% of all of the events. Here's a trophine biopsy showing that this marrow is very cellular and disorganized with a lot of pink stuff in between the cells. If one goes up under high power, you can appreciate that these are immature cells with relatively prominent nucleoli, and there's extensive reticulin fibrosis in this marrow, which likely accounted for the fact that we had such a poor aspirate, which led to me having to photograph individual cells on the smear. When cytogenetics came back, it was a complex karyotype, but it did have one abnormality of some sort of added material on chromosome 22. And this clinical pathological phenotype of an infant presenting with acute non-Down's infant presenting with acute megakaryoblast leukemia that has a very densely fibrotic marrow, and these sort of clusters of densely clustered blasts on the trophine biopsy is typical of the RBM15 MKL1 translocation, and this is a very poor prognosis translocation. This particular translocation only occurs in infants. Here's another infant. He's been sick for a while. He's 18 months of age, and he's been sick since the age of 10 months. He's non-dysmorphic. He has a heart murmur, but he's otherwise well. He has a high white count. It looks like there's a formatting problem here. With a particularly a neutrophilic leukocytosis, he has an elevated absolute monocyte count and has a few nucleated red cells in his peripheral blood. Here's his peripheral blood from low power. You can appreciate the fact that he has a relative leukocytosis, and perhaps from this power may be able to see that he has a somewhat lower platelet count. On higher power, you can see that there are neutrophils here that appear to be mature, but some of the neutrophils appear dysplastic. Here's one with 2 lobes and maybe some hypergranulation. Here's another one with normal lobation pattern, but is completely hypogranular. Others have slightly abnormal lobation patterns in the morphology of the lobes. There are monocytes, some of which appear somewhat immature, and there are also other immature myeloid precursors out in the blood. Here's another view showing another immature monocyte, as well as sort of a hypersegmented neutrophil. Other data, this patient had an increased hemoglobin F for his age. He had a normal bone marrow karyotype, and his FISH was negative for monosomy 7, trisomy 8, and the partial deletion of 7q, as might be expected in myelodysplastic syndrome. But gene testing reviewed that he actually had a somatic mutation, a position 227 of the cDNA in the PTPN11 protein tyrosine phosphatase, entirely typical of one of the RAS mutations that's somatically present in patients with JMML. I know that you reviewed the criteria for JMML earlier today, so I won't go over them here, but just to make the point that in the age of mutation analysis, and particularly somatic mutation analysis, most patients with JMML will be discovered to have somatic mutations in the RAS pathway. Moving on to other diagnoses. This is a 21-year-old man that we recently saw with a long-standing history of Crohn's disease that was treated with immune suppression, including a long-term 6 mercaptopurine treatment. He had a 6-week history of symptoms consistent with macrophage activation syndrome, and he had recently received mass-directed therapy, including steroids, cyclosporin, anakinra, and infliximab, and had very little improvement. He ultimately came to bone marrow aspiration and biopsy, which showed this. It's relatively easy to appreciate that he has marked hemophagocytosis. This macrophage is eating many of its neighbors, including at least 3 red cell precursors. Other cells are eating platelets, and in other fields you could see mature red cells being eaten. But it was relatively easy, actually, to overlook the fact that he also had a large number of these abnormal appearing lymphoid cells highlighted here by the arrow. By flow cytometry, these were abnormal T cells that co-expressed CD3 and CD7, but lacked the T-cell marker CD5 and expressed the gamma delta T-cell receptor, and they were negative for immature T-cell markers. Here is the biopsy showing that these abnormal lymphocytes tend to like to hang out in the sinusoids of the bone marrow, and an immunohistochemistry for the NK cell marker CD56 highlighting the cells packing the sinusoids. And ultimately the diagnosis was definitive by the identification of an isochromosome 7 as well as trisomy 8 in many of the patient's cells. The diagnosis in this case is hepatosplenic gamma delta T-cell lymphoma, and the point of this case is not to raise your awareness of this particular leukemia lymphoma syndrome, but I will describe it here. It's a rare leukemia and lymphoma. It has an abnormal gamma delta T-cell phenotype, often co-expressing CD56. There's an isochromosome 7q in most cases. The sporadic cases are nearly all teenage males, but increasingly we're recognizing immunosuppression-associated cases. We've seen 3 in the last 2 years. And these patients characteristically present with this smoldering hepatosplenomegaly, cytopenias, and may ultimately have a fulminant HLH-like phenotype. The real point of this case was to remind you that hemophagocytic lymphohistiocytosis comes in really 3 flavors, and I tend to think of them in different age groups and clinical settings. The first, familial, usually occurs in patients less than 18 months of age and is typically associated with decreased NK cell function. And this is almost always due to mutations in genes responsible for cytotoxic T-cell granule exocytosis or function, such as peripheral. In the older age groups, in the non-infants but younger children, infection tends to be predominant, particularly the herpes viruses and EBV. And if one sees this, one should also think about X-linked lymphoproliferation in a male in the early school age years. There are, of course, many other infection-associated hemophagocytic syndromes. We've recently seen one with brucella. And lastly, and this was an example of this, was our malignancy-associated T-cell, a malignancy-associated HLH, particularly T-cell lymphomas such as hepatosplenic gamma delta T-cell lymphoma, but we also see it relatively commonly in patients with anaplastic large cell lymphoma. It's important to distinguish what the basis of the HLH phenotype is, because one really needs to treat the underlying cause. Here's a patient, 16-year-old male with a history of chronic digital warts and an episode of atypical mycobacterial lymphadenitis, who now presents with pancytopenia. Here's his bone marrow biopsy. From low power, you can appreciate that this is a very hypercellular marrow. A normal cellularity for a patient of 16 would be about 70% cells. You can appreciate perhaps here that it's very myeloid. There are relatively few megakaryocytes that are apparent. On the aspiration, however, you can appreciate that the megakaryocytes that are present are very dysplastic. They're having multiple separated nuclear lobes. Many of the neutrophils are hypolobated. In addition, there are multi-nucleated and lobated erythroid precursors. So there's trilineage dysplasia here. This is a child with the myelodysplastic syndrome. The differential count on the blast was less than 5% and was highlighted by the CD34 stain, which stains both the immature blasts as well as the blood vessels. So in morphology, we have a hypercellular marrow with multilineage dysplasia and 4% blasts. On the cytogenetics, he had a monosomy 7. And this being a teenage boy and he having monosomy 7, we checked whether or not he had a GATA2 mutation. In fact, he has a germline GATA2 mutation. About 25% of teenagers that present with monosomy 7 will turn out to have germline GATA2 mutations. And this patient, in retrospect, has the classic findings of the monomac syndrome in that he has chronic herpes virus infection, an atypical mycobacterial infection, and now myelodysplastic syndrome. I won't go into the classification of myelodysplastic syndromes in detail, but to remind you that these are clonal hematopoietic disorders characterized by cytopenias, dysplasia, and recurrent genetic abnormalities. Here's the current WHO classification, which is largely geared toward the classification of adult MDS. The provisional pediatric classification of MDS may not have particularly held up over time, but I'd like to point out to you that the WHO classification in the current edition includes a classification of germline predisposition to MDS and AML, of which myeloid neoplasms with GATA2 mutations are common. These are so common that now it's our routine practice in all patients with AML that don't have a simple cytogenetic abnormality to look further for the potential of an inherited germline syndrome. This next case is a 19-year-old female with recent fatigue and a 5-pound weight loss. She had her wisdom teeth extracted and 1 month later had difficult to control bleeding from the extraction sites. She has a white count of 469,000. I got an urgent call from the emergency room, come in and do flow cytometry on this patient. She had a hemoglobin of 7.9, a hematocrit of 22, and a platelet count of 671, showing a neutrophilic leukocytosis with the left shift. She ended up getting a bone marrow aspirate biopsy, which showed sort of a pan-myelosis with a marked relative myeloid hyperplasia. It's difficult to appreciate in this case, but there were many basophils here as well as abundant eosinophils. The megakaryocytes tended to be small and hypolobated, and in scattered fields you'd have these storage-type sea blue histiocytes. By flow cytometry, of course, there were relatively few blasts, only about 4.8% in the bone marrow, and these phenotyped as myeloblasts, whereas the majority of cells were granules. The biopsy showed a markedly hypercellular marrow that even on low power you can appreciate the eosinophilia. And of course the cytogenetics showed a translocation 922 and a FISH positive for a BCR able in the majority of cells and an RT-PCR showing a P210 transcript. Diagnostic of chronic myeloid leukemia and in the absence of an increased blast count in chronic phase. Remind you that chronic myeloid leukemia is one of the myeloproliferative neoplasms defined now by molecular genetic methods. It's a clonal stem cell disorder. It's characterized by neutrophilic leukocytosis with a left shift, basophilia, and eosinophilia are typical. Patients may have thrombocytosis, but the platelets often don't work particularly well, perhaps accounting for this patient's bleeding diathesis. It's defined it's a molecular defined disorder by the BCR-ABL translocation, and it can evolve to blast crisis. Interestingly, unlike in the adult population, pediatric patients with blast crisis typically evolve to B lymphoblastic crisis, not myeloid blast crisis. And we've seen many patients presenting with apparently de novo Philadelphia positive ALL that in fact actually had lymphoid blast crisis of CML. The other myeloproliferative neoplasms that we occasionally see in pediatrics are polycythemia vera, characterized by JAK2 mutations, or essential thrombocytosis characterized most commonly by JAK2 or CALR mutations. So the last case that I'm going to show you is a case that we see about once a year, and I trick the fellows with it every time. This is a 9-year-old male who presents with pancytopenia, bone pain, and what we increasingly are seeing referred from the radiologist as diffuse marrow signal abnormality. That was the indication for a bone marrow procedure. If you look at his peripheral blood, however, you can appreciate that he had pancytopenia, and you could see these occasional large cells that look like they could be erythroblasts or maybe megakaryocytes with fine chromatin, punched out nucleoli. Some of the cells have these large vacuoles, making one even think about Burkitt leukemia with the diffuse marrow involvement picture. When we got the bone marrow aspirate, you could see more of these cells, but here on the aspirate, you have these somewhat discohesive and yet somewhat cohesive cells. When we got this is pretty typical of this disorder. Often these vacuoles have a pearls on a string kind of appearance. Here's the bone marrow biopsy, which looks very different than leukemia. These are actually relatively large cells. You can see them packeting. One might even imagine that it had sort of an alveolar structure to it here, where they're falling apart. And here they are, and they're really sort of tightly crowded cells. And then when one does the immunohistochemistry, you can appreciate that these are in fact rhabdomyoblasts that are positive for desmin and myogenin. The karyotype came back with the translocation between chromosomes 2 and 13, and the FISH with the translocation involving the FOXO1 gene. And this is the one solid tumor that I've seen present as leukemia in the peripheral blood, leukemic alveolar rhabdomyosarcoma. So thank you for this, allowing me to give you this whirlwind tour this morning. I think we're right on time.